This patient has a very dense cataract and doesn't dilate very well either. So I just made a side port incision. You would probably want a little larger pupil than that. So our choices are to use a device, iris retractors, or stretch. So I'm going to put some air and then trypan. You're going to feel a little sting for a few seconds. And now we'll inject some OVD to both deepen the chamber, expel the OVD, air, and enlarge the pupil. And that's a much better pupil now. So this is Provisc, which I'm going to inject just a little bit on top of the IOL. The chamber is very deep now, much deeper than it was. And just make that little incision in the capsule. And you really like with these relatively mature lenses to have a nice deep chamber when you do the rhexis, because it's far less likely that the rhexis would run out into the periphery. And again, this is not a mature white cataract, but it's only one step removed from that. So I'm just following the curve of the pupil, but I'm making a little smaller rhexis than I might ordinarily make. So I'm going to aim for something that's a little over 4 millimeters here. The smaller it is, the less likely it is to run out. So this is just some hydrodissection on each side. Now, it is so common for dense nuclei to have a lax zonule. The two go hand in hand. I'm going to do 360 degrees of viscodissection. That's more than 180. And I'll get the subincisional area like so. I'm going to test the infusion capacity here. Make sure fluid comes out of both sides. You feel a little pressure. That's normal. We're evacuating some of the OVD. There's no way not to feel some pressure. Quadrant removal. Just aspirated those bubbles that were somehow in the infusion line. Back to sculpt. Now these whitish nuclei are often very brittle, like the cornea, and chop easily without a red reflex, like that. So that's one nice thing about them. And as soon as I get another chop here, not sure if I got one there or not.
Doc is hurting, huh? It's okay, right?
It's okay. I'm going to take out this quadrant removal. So now we've decompressed the capsular sac. Brittle is good. Super dense, not so good.
It hurts, right?
A little pressure, yeah. And reassurance to the patient. They all feel some pressure, of course.
My eyes are open now.
Yeah, I'm going to ask you not to talk. Okay. So your head will be nice and still. Thanks. That little, it's really like a heminucleus, thin, and it flips over and over. I'm going to try and get it to just come out here like that. Good. Yeah, you're doing great. Nice and still. So we got two little quadrants left here. And now I'm going to increase the flow rate here. Take it up to 50 cc's. We're at 42, but I'm going to 50. Because I want more attraction. There's some significant mass to this lens material. So if I can get a little bigger flow stream going, it'll come to the tip better. See, pieces just came out of the posterior chamber and came up. Good. So now we're ready to go to cortex removal. Now you can't tell in 2-dimension, but I can tell in 3. When I come out, the chamber really shallows. Low ocular rigidity. Well, that's not important now, but once there's an IOL in there, it is. So if I come out after I remove the OVD after IOL insertion, that IOL could come right up to the endothelium. Well, I sure am not going to let that happen. So how do we prevent that? Okay, so cortex removal is gone. Subcapsular epithelium vacuumed. We're ready to put in the OVD. Now it's Provisc before IOL insertion. By the way, there's a little piece of lens material right there. You see that? I'm going to take that out. We have the INA tip again. Yeah. Not so little, turns out. That's going to need the phaco tip. So I'm going to put it down here in the bag and go back in. Well, it doesn't want to stay there. We'll go back in with the phaco tip and take it. Because it would take a while to press that into the INA tip. Go to Sculpt. It really wants to follow the current here. Let's see if we can't get. So I'm going to aim the infusion port at it as I try to get it to move out where I can get it. Now, worst came to worst, what would I do? I put some here. I just got it now. And now another piece shows up. Okay, come on, guy. So the inertia of those pieces made them hide from the flow stream. OVD. It's difficult to measure his biometry pre-op. So I'm going to fill his anterior and posterior chamber with Provisc and get his IOP to be in the normal range. Well, let's just see what it is. That's good. And now we're going to take an aura reading. Okay. So I need you to look at that light.
Yes, sir.
Looks good. Let's capture right there. Perfect.
It goes away then.
'21 it is. So we've now selected the IOL based on the aura reading. And we're going to insert it. It's a 21 diopter single piece SN60 WF IOL. I'm going to tuck that trailing haptic in and optic through that smallish rexus. And now we're ready to remove. Now remember we talked about low ocular rigidity here and chamber shallowing, so what are we going to do? I'm going to go behind the IOL and remove OVD from behind it. But I'm not going to remove all the OVD from the anterior chamber. Syringe BSS, and it's a good thing I didn't, because the IOL came up, but it's about 1 millimeter from the cornea. So now I'm going to do stromal hydration. Keep looking straight at the lights. Deepen the chamber. Nice deep chamber now. And then I will irrigate out the remaining OVD like so. So we had no chance to lose the chamber. We really couldn't lose the chamber because we always had either OVD or BSS in it, one way or the other. And now we're ready to put the antibiotic in and we'll be done. So kind of keep that in mind. They're usually highly myopic eyes, but not necessarily. They have low ocular rigidity. And when you come out with your phaco or your INA tip, and that chamber really shallows, at the end, don't remove the OVD from the anterior chamber with your INA. Consider doing it the way I just did it here. Look straight into the light, please. Good. Yeah, it's fine. We're done. There's some eccentric pupillary dilation, so you see more of the IOL here than there. It's more dilated on this side, more dilated superior, but it's fine.